Thanks, Corey. Always a pleasure to join these echo sessions. I very much enjoy being here as an attendee or presenting, and I'm very happy to be here today to talk about this subject because, as Corey alluded to, I think it's a really a critically important subject, one that we um, probably don't spend as much time talking about as we should. And I think part of the reason that that happens is a bit of a sense of futility in terms of how to actually approach patients who are using stimulants or amphetamines. And hopefully we're here to dispel that a little bit today, that there's evidence-based harm reduction interventions, treatment recommendations that can and should be considered. Uh, just by way of introduction, I'm a physician here at St. Paul's Hospital in Vancouver, and I do have a specific research interest in stimulant use disorder. I suppose I should mention my disclosures. I don't have any involvement with any pharmaceutical companies or industry at all. I do hold some grants related to the management of stimulant use disorder and some clinical trials, but nothing that really, I think, affects what we're going to talk about today. Specific learning objectives for this session, and we will be covering a lot of material in a short amount of time, but we're going to quickly review the prevalence of methamphetamine use, factors contributing to use, patterns of use, and associated harms. Then we move into a discussion on harm reduction approaches to help mitigate the adverse effects of using methamphetamine and how they might also apply in rural, remote, and urban contexts. And lastly, going to talk about treatment options to support client-defined goals, wellness and recovery, and also hopefully refer you to some resources which may be useful in your clinical practices. Next slide, please. So, by way of introduction, we're talking about stimulant use disorder today, but quite specifically, we're talking about methamphetamines, and there are some important distinctions between methamphetamine and other psychostimulants. As you're probably all well aware, amphetamines and methamphetamine specifically is a synthetic central nervous stimulant known for its very potent psychoactive effects. It is available in a number of different forms. It's available in my context, at least in the form of crystal meth, which is the most common form that we see, which can be in a crystal or crushed up into a powder. It's also available in a salt form and a base form, so you might find it in crystals, powders, tablets, kind of waxy rock-like chunks, depending on the specific formulation. The effects are quite similar, depending on or irrespective of the formulation. It is very water soluble. It can be effectively snorted, injected, swallowed, or smoked. It can also be used PR or booty bumped or hooped, which is not included here, but there are many routes to and preferences for how people might use their amphetamines. And it's becoming an increasingly common stimulant in I think all of our respective contexts. Next slide. Methamphetamines versus amphetamines, just by background, methamphetamine would be a type of amphetamine. Amphetamine is a broader class. Methamphetamine is an amphetamine with an additional methyl group that makes it quite water soluble, and it allows it to cross the blood-brain barrier very quickly. So methamphetamine causes a large release of neurochemicals at a very rapid onset compared to other amphetamines because it's so rapidly absorbed. And the subsequent effects of that we'll talk about a little bit here. Well, amphetamines as a whole, there are amphetamines that are regulated and available by prescription, including things like Adderall, which is mixed amphetamine salts, or dextroamphetamine. And methamphetamine in Canada is unregulated. Disoxin is the only prescribed version of methamphetamines out there, which I don't believe is available in Canada and is used sparingly in the United States. Next slide. So prevalence of use, I think as we're all aware, the prevalence of amphetamine use and methamphetamine use specifically in Canada has been changing pretty dramatically over the past decade. And I think that this is a trend that's been going on for some time, and we're a little bit late to the game and starting to really appreciate it. The last kind of national survey we have on this subject is the 2019 Canadian Alcohol and Drug Survey, and that survey, which polls Canadians across the country and asks them to self-declare their experience using substances, elicits a past year use of less than 1% of using methamphetamines and a lifetime use of about little over 3%, so 3.2% lifetime use of methamphetamines. I will again point out that is self-reported use, so likely some underreporting here. So not the most common thing, as far as the general population goes. But I want to just highlight that that's also not rare. That means, 1 in 25 people, a little bit more than that, do have some experience using methamphetamine. So not as rare as perhaps we like to think in our personal lives. The lifetime prevalence of both unregulated methamphetamine and amphetamine use in British Columbia, a little bit higher at 2.1%. Again, not common, but not rare. And this is at a population level. Um, Amongst populations of people who use drugs, we see a lot more use, and a really shifting pattern here. So crystal meth was the most commonly reported substance used in the past 3 days amongst the BC Harm Reduction Client Survey, amongst clients at harm reduction sites across the province. 60% of clients endorsed the use in 2018, up to 72% in 2019. So you can see amongst people who use drugs, much higher prevalence. Patterns of use, like as we alluded to earlier, the routes of administration are broad. It can be used in many different routes, but inhalation is the most common route of administration, at least as per that BC Harm Reduction Survey, which I think gets us a pretty good snapshot of current trends in our province. There has been an increase in injection use from about 17% in 2008 to 32% in 2018. So a pretty marked increase in injection use of amphetamines over that decade. And again, I think that's probably not a surprise to any of us who are in clinical practice here. As far as demographics go, it's used in a broad range of demographics. There's certainly no um, unlike maybe a decade or two ago, where it was often used in pretty specific subpopulations. It's pretty broadly used these days. However, there is higher use reported amongst males compared to females, and higher use especially amongst people who are unhoused or unemployed. Often used either with other substances, or in patients with co-occurring other substances, including opioids, cannabis, and alcohol. All of those are associated with increased crystal meth use, again in that BC Harm Reduction Survey. So more taking a step back though, and looking kind of at trends over time across North America, we have seen a dramatic rise in methamphetamine use across the country, and the consequences associated with that. We published a study, it's not referenced here, in Ontario, that noted a 15-fold increase in hospital presentations for methamphetamine use since the early 2000s till about 2020. And specifically, the co-occurring methamphetamine and opioid use together has increased dramatically across North America. In BC, 54% of people who use opioids or stimulants report co-occurring use, and we're all, I think, unfortunately aware of how prevalent methamphetamine has become in overdose deaths in our province, and in really similar trends across the Canada and the US. The second most commonly detected substance in unregulated drug deaths in BC, and that's been increasing since 2016, with 30% in 2016 up to 50% in 2024. So very commonly implicated in overdose deaths, if not whether or not it's directly involved in the death itself is maybe a more complicated question, but there's a presence of amphetamines that's been climbing. So that's a lot of background, I think, which is, again, I think helpful to provide some context, and again, not news to many of us. But let's talk a little bit more about some of the clinical factors contributing to use, and some of our treatment options. So there are many there, as I talked about, there are no specific subpopulations any longer where methamphetamine use is restricted. It's used broadly amongst populations of people who use drugs in an increasingly common fashion. But there are factors that are known to contribute to increased likelihood of methamphetamine use. That does include individual factors, so people with a history of mental health and trauma more likely to use methamphetamine. Um, for some, their use is attributed to curiosity and experimentation, much like with many other substances. And it's a very common substance used for sexual enhancement, or in the chemsex or party and play communities. So those are some of the individual factors that may be associated with increased use. Social factors that some people attribute their use to include social connection, which again is not unique to amphetamine. I think it's a really common association with many substances. But work-related stress or performance at work is again really common, I think, for stimulants specifically, and increasingly that's been a factors related to methamphetamine use. And then certainly there are environmental factors that contribute to methamphetamine use and have contributed to the rise in amphetamine use that we're seeing, including its proximity, its availability, its accessibility, its acceptance as just sort of a more and more common part of the drug culture in BC and elsewhere. Maintaining alertness here is listed under environmental factors. I would almost put that that's somewhat of an environmental factor or an individual factor. As many of you, I'm sure, have seen, amphetamines stimulants as a whole are often referred to as functional drugs. People use them, or at least often start using them for a reason, and those reasons may vary. But certainly maintaining alertness either for performance at work or for survival in people who are unhoused or unstably housed, really common rationales for at least starting to use amphetamines. And then individual trajectories take over. So I'll put a pin in that last slide because I am going to revisit some of those things later. But let's talk a little bit about the harms that we know that are associated with methamphetamine. And I work in an acute care setting, so these are all too apparent for me. Stimulant-induced. I should say that methamphetamine and the associated sympathetic drive that's associated with stimulant use as a whole, but methamphetamine specifically, can lead to profound acute harms in any and all systems of the body. These are just a small sample of some of the acute methamphetamine harms that we can see, but that are more common. And I think by and large, the most common one that we see these days, at least in the emergency room or St. Paul's Hospital, are things like stimulant-induced psychosis. One of as you can see just below that, we have there's a few that are quite overlapping here. So we have stimulant-induced psychosis, we have overall anxiety or confusion, impulsive or violent behavior, and stimulant overamping are all listed here. And those are all somewhat related but distinct presentations, I think, along a spectrum of stimulant intoxication. So mild intoxication may lead to euphoria or pleasant symptoms, but may certainly cause anxiety or confusion in some people who are less comfortable with it. That is pretty closely related to stimulant overamping, which would be sort of a subjective description of somebody who's having a more kind of intense experience than they were aiming for, and may experience anxiety or confusion, palpitations, chest pain, paranoia, fear, anxiety. Those are all kind of a part of that overamping picture, but still tend to have an intact sensorium, and are aware of where they are and kind of what's going on. Certainly that can start to trend towards more disorientation, which can lead to all the way to stimulant-induced psychosis, which is a loss of awareness of one's environment, delirium, paranoia, hallucinations, etc. We aren't going to get a lot into discussing the management of these harms. I'm more than happy to talk about that in the questions if needed. But I will point, I'm going to talk about this later, but the American Society of Addiction Medicine and the American Association of Addiction Psychiatry have put out a guideline a little over a year ago for the treatment of stimulant use disorders that does go into the management of some of these complications in some detail. So if we don't cover any questions today, that is a resource we'll be plugged at the end here. I'm going to mention that now as a place to go back to related to some of these harms. The impulsive or violent behavior is something that I think or lack is also associated with stimulant use and acute intoxication, which can lead to a variety of sort of more impulsive behaviors. Drug poisoning or the unintentional consumption of fentanyl from an adulterated drug supply is all too common and something that we unfortunately see quite regularly here in the hospital. And then for people who have been using methamphetamine regularly and then stop, withdrawal symptoms for amphetamines can be quite profound. We often, I think, underappreciate or we don't validate these symptoms because they're not as dramatic as alcohol withdrawal or opioid withdrawal, but they can be really debilitating, really distressing, and really prolonged. So dysphoria, depression, irritability, difficulty concentrating that can last for days to weeks following cessation of stimulant use can be a really acute and distressing harm. Next slide. Well, speaking here just a bit about some long-term methamphetamine-related harms, and I'm going to skim over this a little bit more quickly for the lack of time. But certainly, cardiovascular conditions can be triggered or exacerbated by that surge of catecholamines that's associated with stimulant use, in particular amphetamines. That's everything from myocardial infarctions or heart attacks to strokes to other infarcts, aortic dissection, pulmonary hypertension, lots of cardiovascular complications that are just related to that profound catecholamine surge and that sympathetic drive that gets turned on when using stimulants. Um, Things like nutritional deficiencies, oral health problems, psychiatric worsening of existing or new psychiatric conditions, risk of infections, challenges with insomnia. All of these can again be associated with sort of longer term, in some case short term, but also longer term methamphetamine exposure. So, talking about harm reduction, then, with those harms in mind, I think many of the approaches and philosophies here are the same as with many other substances. But again, I find that we sometimes just don't talk about them quite as specifically around people who use stimulants. But it's really important to have the same conversation, this very similar or the same conversation amongst people who use stimulants as you might if somebody's using opioids. That starts with education around potential harms, resources that might be available, treatment options if somebody might be interested in that. Supervised consumption and overdose prevention sites are very much on the table and available for people who use stimulants because we know that in the context of a adulterated and unpredictable drug supply, overdoses still happen. Along the same lines, drug checking, and access to clean supplies, I think is just part of the backbone of harm reduction for anyone who's using substances in the current era, along with take-home naloxone. Again, for people who, especially those who heard their use is associated with sexual intercourse, that ensuring that people have condoms and safe supplies for sex, I think, is really important, and access to STI testing, even HIV pre-exposure prophylaxis may be helpful in a variety of populations, but especially those who use amphetamines as a part of a party and play or chemsex. And then basic discussions on things like oral hygiene, nutrition, and hydration to avoid some of those complications, I think are really meaningful and fundamental and easy conversations to have for people who are using stimulants that kind of respect their individual goals, but also can help reduce some of the harms associated with ongoing stimulant use. Many of these harm reduction approaches, as I said, are not unique or new to stimulants, but I think it's important that we really focus on populations who use stimulants and remember that these lessons apply to them as well. Some of these approaches are more challenging than others to implement in rural and remote settings, but there are ways to adapt. Some of these approaches, including things like mobile harm reduction approaches, mail-in drug checking tools, which are available in the province of BC, virtual health and virtual primary care, and access to peer support networks can all be just as applicable in rural, but just as applicable or more applicable in rural and remote settings. So while that does present some unique challenges, there are ways to address that. And then lastly, and I'm just cognizant, I'm aware that I'm speaking quickly and I'm cognizant of our time. We'll have lots of opportunity to revisit some of this, but I've just got my eye on the clock. When we're talking about treatment of stimulant use disorder, again, this is what I was alluding to in the beginning. I think we we don't spend as much time talking about available treatments for stimulant use disorder as we do for other substance use disorders. But for people who do have a diagnosable disorder, for people who are seeking to reduce their use or abstain from using, there are evidence-based approaches that are available. So this slide is just speaking to kind of the diagnosis itself, which is, I think everyone here is probably familiar with our DSM-5 criteria, and there is a specific diagnostic label for stimulant use disorder that's based on those same DSM-5 criteria that we would use for other substances, and applies to both methamphetamines and amphetamine use disorders. So if somebody has obtained that diagnosis and is actually seeing somebody in an inpatient setting or an outpatient setting and is looking at treatment options. They're trying to cut back or stop using amphetamines and struggling. There are, as I said, evidence-based approaches that we can employ to navigate the situation. So before talking about those, I just want to kind of call back to that slide where we're talking about kind of reasons for use and the reasons why people might use these substances. And I think it's really important to bear that in mind because everything that I'm going to talk about here, I think, is really important and still may apply. But it's also fundamental, like with any substance, to understand why people are using, like what a substance does for them and what role it plays in their life, or because for somebody who is using, again, for mental alertness, for instance, because they're unhoused and they're afraid of being assaulted at night, nothing that I'm talking about here as far as psychosocial interventions speaks to that specifically, but it's very clearly a fundamental need to address some of those underlying causes, if that's contributing to their patterns of use. And that's probably the most important starting place before we start talking about some of these other clinical interventions. But so never forget to understand kind of the role that a substance plays in somebody's life, and doing as best we can to address other medical comorbidities or social determinants of health that might speak to that. But and that's probably the biggest bang for your buck overall. But as far as specific interventions, we do have some evidence-based approaches. And the gold standard for the treatment of stimulant use disorder are psychosocial approaches. So there's a whole breadth of psychosocial approaches out there. Some more standardized than others, some better studied than others. And we're not going to get into the whole kind of the entire list, but there's 4 specific psychosocial interventions that have been evaluated for the treatment of stimulant use disorder and demonstrated some benefit. And the by and large, the most consistently evidenced approach for stimulant use disorder is contingency management, which is a psychosocial intervention that is not particularly available in a province, but is very easy to design and implement if you have kind of the interest and the support from your clinic or community or health authority or what have you. And Dr. McKay is going to talk about this in the latter half of the presentation. For those who have not heard of contingency management, it's a very simple premise. It's based on the idea of operant conditioning, or using positive rewards, small repeated positive rewards to help incentivize behavior change. For the purposes of, and this applies broadly for the treatment of stimulant use disorders, of other substance use disorders, and is even used outside of the addiction world as an effective way of kind of helping to promote behavior change. For our purposes, it's using incentives and intangible rewards for positive behavioral change. Oftentimes, an immediate reward provided for somebody who's achieved a behavior change, whether that's abstaining for stimulants for a week, reducing their use, or perhaps just engaging in care around their stimulant use, using kind of consistent and repeated immediate rewards to help promote that behavior change is the premise of contingency management. It's not Lindsay's going to talk about their program, I think, a little bit, but they're not that sophisticated or complicated to set up if you have kind of the will and the support, and is by far the most evidenced treatment for stimulant use disorder. For those who are familiar with the concept of number needed to treat, the number needed to treat for contingency management to help promote short-term abstinence from stimulants is as good as 4 or 5. So that is in the kind of spectrum of medicine, that's a phenomenal NNT. Moving on, the other most common kind of approach that gets talked often about is cognitive behavioral therapy, or CBT. For those who aren't familiar with cognitive behavioral therapy, it is a framework, essentially, an approach to help describe kind of how our thoughts, feelings, and actions are all related. So for the purposes of stimulant use disorder, it can help manage stimulant use disorder by helping people understand kind of how their thoughts and feelings affect their actions, and helping change those behaviors. It can help identify triggers. It can help teach coping skills to manage those triggers, and has a less consistent evidence than contingency management, but certainly a consistent signal in the literature that it can be a really helpful tool in reducing methamphetamine use or preventing return to use. And it can be while the evidence isn't there necessarily for combination treatments of cognitive behavioral therapy and contingency management, there's no reason that those two treatments can't be used together. Although I will say that CBT is more difficult to access and takes a bit more training to run CBT programs. The third approach that is talked often in literature that I want to highlight today is something called community reinforcement, and this is really kind of, in my mind, the ultimate, like what we should all be aspiring towards, because it really does speak to, as I mentioned, kind of understanding the role that stimulants play in somebody's life, and kind of looking at all aspects of somebody's life and how we can support them in their goals, help build that recovery capital, and help support them kind of in their trajectory of reducing their use of stimulants or abstaining from them entirely. It includes a broad kind of 360-degree assessment of all of the factors in somebody's life that might contribute to their use, and includes a variety of interventions, including coping skills training, social social, familial, and recreational supports, vocational reinforcement, and a real focus on positive and healthy behaviors. While contingency management is the gold standard as a standalone therapy for the treatment of stimulant use disorder, the best evidence intervention we have in the entire literature is the combination of contingency management, which is really helpful, especially immediately at helping to kind of engage somebody, and community reinforcement, which really provides that sustainability and that permanence of the effect. So the combination of those two things has the strongest outcome in the literature. And then the last thing that I'll refer to, just because it is available in some settings in the province, is the matrix model, which is sort of a comprehensive, multifactorial approach, which is available in some clinics, incorporating things like CBT, contingency management, 12-step facilitation, and motivational interviewing. It's a very structured outpatient or inpatient program that goes over 16 weeks and does have, again, a little bit less consistent evidence, but some promising evidence for the reduction or promotion of abstention from amphetamine use. So the last thing that I'll talk about, because I'm already almost at time, and again, referring back to those guidelines that I mentioned already. So for any of you who has an interest in this subject, I would really strongly encourage you to look at the ASAM AAP guidelines for the treatment of stimulant use disorder. They are a little dense, but contain a lot of information there. And to my knowledge, they're the only guideline of this nature that's out there. And one of the topics that they do speak to is pharmacotherapy. I think it's there's a misconception out there that there are no effective medications for the treatment of stimulant use disorder, and there are no FDA approved medications for the treatment of stimulant use disorder. There's no medications who have widely helped demonstrate the ability to promote abstinence in a broad range of populations in repeat studies. But that doesn't necessarily mean that there are medications that can be really helpful. These are the ones that are highlighted in these guidelines as having demonstrated at some point signals for benefit in some population. For people who are using methamphetamines, that includes bupropion monotherapy, or potentially more effective would be the combination of bupropion and naltrexone, which was demonstrated to have a really pretty profound effect in one large U.S. Randomized control trial. They do highlight that there are kind of some of the considerations where you might consider using these in the context of other comorbid substance use disorders to try and kind of take advantage of effects that might extend beyond the stimulant use itself. Topiramate is another medication that has demonstrated some benefit in some studies for methamphetamine use disorder. Frankly, better evidence for cocaine use disorder, to be honest, but is something that could be considered, especially if somebody has a co-occurring alcohol use disorder, because again, it has good evidence for its role in that setting. Mirtazapine has demonstrated some benefit for reduction of use or abstinence, especially amongst populations of men who have sex with men. Particularly, and is recommended also in those with co-occurring depressive disorders. And the prescription psychostimulants, I think, they've highlighted methylphenidate as the one that's best evidence for amphetamine use specifically. But prescription psychostimulants do probably have a role in the treatment of stimulant use disorder, including amphetamine use disorder. The literature is pretty sparse in this area. And I'll take this opportunity to highlight for anyone who's in the Lower Mainland, we are running a trial at St. Paul's Hospital right now called the ASME study, which is looking at the combination of Vyvanse, high-dose Vyvanse versus placebo, combined with contingency management versus treatment as usual. If you have any patients who might be interested in participating in an RCT looking at high-dose Vyvanse for the treatment of methamphetamine use disorder, please send them to St. Paul's, or you can look up, it's called the Ask Me study, ASCME. You can look up our contact information online, or just send me an email, and I'm more than happy to provide more information on our ongoing RCT. Next slide. I think we're almost done here. So in summary, just at time, amphetamines are commonly used amongst people who use drugs, and the prevalence of the use has really dramatically increased over the past decade. There's been an increase in co-occurring opioid and methamphetamine use in North America. It's certainly implicated in the ongoing toxic drug crisis and in many overdose deaths. Harm reduction is still a cornerstone of our approach to people who use stimulants to help prevent associated harms. Psychosocial treatment interventions are the standard of care and remain the standard of care for stimulant use disorders. They can be effective treatments. They can be quite simple to establish, as Dr. McKay will talk about, and really are something that we really should be emphasizing more. And there are pharmacotherapy options as well that may be considered after weighing the risks and benefits, depending on whether somebody has been able to access psychosocial treatments, whether or not they found benefit from them. There's certainly medications that might be considered. If you have any questions or concerns or curiosity as to whether pharmacotherapy may be in order, you can always consult the 24/7 line or the race addiction line if you want to talk it through with one of the specialists. Next slide. So here are the resources, including the BCCSU stimulant disorder practice update, as well as the ASAM AAP guideline I keep referring back to. I can't recommend strongly enough, as well as some other virtual care, harm reduction, and community resources. And feel free to call us on 24/7 if you ever want to talk through a case. I may not have the answer, but I'm always happy to chat.